Hi, this is Kendrick with worldmedicalschool.org. We have recently changed over from the medschool.com. I'll talk more about that after we talk about vertigo. Vertigo is one of those problems that a lot of doctors kind of wince at when it comes in the door because it can be pretty complicated, and a lot of the problems associated with vertigo are hard to treat. But we're going to talk about some of the ways that you can actually make a real difference for your patients with vertigo. So, vertigo is going to be a problem with any of the parts of your brain or your inner ear that affect your balance. And so that could be the inner ear, the vestibular nerve, vestibular nuclei, or problems with the cerebellum. So the problems I've got here at the top, benign paroxysmal positional vertigo, labyrinthitis, vestibular neuritis, Meniere's disease, vestibular migraine. These are some of the most common problems and some of the most likely to be tested on this subject. But I've also got in red here the vascular causes. These are the ones that we really want to worry about. So that could be, a TIA or a stroke, and there's vasovagal syncope that also can cause a form of dizziness, and otosyphilis can also cause some vertigo. So to start out with, I just want to get the really important or the really dangerous stuff out of the way so we can kind of settle down while we think about the rest of these things. Because you don't want to miss a stroke, obviously. You don't want to miss a TIA or a hemorrhage or any kind of neoplasm or tumor. So if somebody comes in your office complaining of dizziness and they're over 50 and the dizziness is really bad, it doesn't allow them to stand, then you probably want to get them into the hospital real quick. And get an MRI or a CT, figure out what's going on, especially if they've got risk factors for cardiovascular disease like hypertension, diabetes, smoking, or a history of CVD. Of course, if somebody's got recent trauma and they're dizzy, it's a good idea to get them in. If they're really in severe pain, then we want to learn more about what's going on. Abrupt onset doesn't have to be a serious or emergency situation, but if you add it to some of these other risk factors, then you really want to make sure that you get them checked out with some imaging. And other neurological symptoms, persistence after treatment. So these are some of the things that we want to really worry about getting figured out quickly and ruling out some of the more serious causes. So now that we've ruled out that your patient has something life-threatening, we can kind of settle down now and start thinking about the different causes of vertigo that aren't so serious. One of the most common that you're going to run into is benign paroxysmal positional vertigo. A lot of times people will leave out either the paroxysmal or the positional, so benign positional vertigo, benign paroxysmal vertigo. Means the same thing. And this is caused by, in most cases, likely it's caused by a dislodged otolith, so a little crystal that's floating around in the semicircular canals and tickling those little hair cells in there and making you feel like your head's spinning or you're spinning. So the history, it's going to be lasting just a minute, and it's going to usually be when you change head position, like getting out of bed, reaching overhead. Some of the ones that I've heard often are kind of like looking up at the shower head when they're in the shower. People have a lot of this. So this is something that is actually really treatable, and a lot of the doctors that I've been with haven't actually done anything for it. And so it's probably something that I'm guessing is going untreated in a lot of cases, or mistreated, which we can talk about. Here's probably a good time to just mention the difference maybe between vertigo and dizziness due to syncope or other reasons. Vertigo is usually associated with a feeling of movement, like the room is spinning, for example, and it usually has a little bit of a nausea associated with it. Whereas if you ever stood up too fast and you got lightheaded, that's a kind of dizziness too, and patients will say the same thing. They'll say dizziness for either of these, but I think they're two different sensations. And so if people feel like they're going to fall over, and it's not really associated with a feeling of movement, it's probably more of a dizziness or a near syncope, and we'll talk about that a little bit at the end, but that's not the focus of this. So if we want to really find out if this is benign paroxysmal positional vertigo, the Dix-Hallpike maneuver is the maneuver of choice. So the patient's going to sit down, turn their head to the side, and lay back from sitting while they turn the head to the other side. And they'll get the feeling of vertigo, and they'll get their nystagmus going. And if you see that, then you know it's benign paroxysmal positional vertigo, or at least you have a pretty good idea that it is. And you have a way to treat it. So the Epley Maneuver, I'll talk about it on the next slide, but it's around 80% effective, and I've actually not seen a doctor do it. So I think that it's something that people are not utilizing as much as they should. And again, we'll talk a little bit about how to do it. But with both the Dix-Hallpike maneuver and the Epley maneuver, you really need to go on YouTube and watch a video. I've got a video under my one of my playlists that you can look up if you want to go to the channel. But an important note here is that you don't want to use meclizine or any of the vestibular vestibular suppressants. And the reason for this is because it inhibits the compensation that goes on in the brain for this dislodged otolith. And a lot of times people can get unstable. So especially if you've got elderly patient and you give them meclizine, then they're going to be less stable and more likely to break a hip or something. So the Epley maneuver, I could read you this slide. It probably wouldn't make much sense to you. So if you want to pause the screen and read through it, you can. But basically, you start with the patient laying down, or you start with the Dix-Hallpike maneuver, and then you're going to turn them 270 degrees and bring them up in that same position. That'll make sense if you watch the video. Next on our list is Meniere's disease. I looked up a few different pronunciations with this. It could be Meniere's or Meniere's or Meniere's, which is the most French sounding, so I'm going to go with that one. Meniere's disease sounds smarter when I say it. So it's caused by possibly by endolymphatic hydrops, or basically too much fluid in those semicircular canals. So they're not totally sure why that would be, and they haven't really nailed that down as the cause, but that's what they still think is the cause. And it's going to look like a recurrent separate episodes of vertigo. And each episode will last hours to days. And you also get some hearing loss, and this is key because we'll see this being different in some of the other diseases that we're going to go over. So hearing loss, especially of low frequencies, tinnitus or ringing in the ears, or a feeling of fullness in the ears are all associated with Meniere's disease. Nausea and vomiting is also common, and it is common with basically all these that we'll talk about. So the diagnosis is made mostly just on those symptoms that we just talked about. You have to have at least 2 episodes lasting a half hour apiece. There has to be some hearing loss that you see with audiometry, and some tinnitus or fullness in the ears. And the way you treat it is classically with low sodium diet and diuretics, and we still do that. But we try like some of the migraine diets, the migraine medications, sometimes benzodiazepines and antiemetics, like meclizine, for example, can all be used to treat this. And there's not a real consensus from what I can see about what first-line therapy is for Meniere's disease. But it is reasonably manageable from what it looks like in the literature. Vestibular migraine is basically a migraine that affects the vestibular apparatus. So this affects a lot of people that have migraines. About 10% will have some vertigo with their migraines, and it doesn't necessarily happen at the same time, but it often does. So if you have people with chronic migraines, a lot of times with photophobia, and they're getting this dizziness, then this is probably a vestibular migraine. And the big point here is that there's no auditory symptoms, because really this looks just like Meniere's disease. If, for example, if there's no headaches, then this will look exactly like Meniere's disease, besides the fact that there's not going to be any auditory symptoms like the tinnitus, the fullness, or the hearing loss. So again, it's a clinical diagnosis. I think I've got this written on all these slides here. And you kind of just put these pieces together. You want to, especially though with this one, rule out episodic ataxia type 2. And this you can rule out with genetic testing. I didn't know anything about episodic ataxia type 2, so I looked it up. And basically it's just how it sounds, episodic and ataxia. You get some vestibular problems, and it happens throughout your life. So if there's vestibular migraine that isn't associated with headaches, that isn't going away with treatment, you might want to do some testing for episodic ataxia type 2. So migraine medications should keep this under control. Migraine diets and lifestyle changes that are all associated with migraines. And then benzos, I've got asterisks here just because it's kind of questionable whether or not they're going to help, but a lot of people try them. Labyrinthitis is another pretty common condition. Vestibular neuritis is pretty close to the same thing. It's just the itis is in a different spot. So when we're talking about itises, a lot of times the causes are the same, just anything that causes inflammation. Here, viral is the most common, but you can get an labyrinthitis or vestibular neuritis from trauma, from bacterial infections, from stresses, from drugs. All those things can cause labyrinthitis or vestibular neuritis. It's going to look like acute onset of vertigo, often with loss of balance or loss of tolerance for movement in the head. Nausea, vomiting. I don't think there's really diarrhea. I think I just accidentally put diarrhea on there. Tinnitus and hearing loss, ear fullness are all associated with labyrinthitis, not so much with vestibular neuritis, because that's not going to affect the same nerve. So the diagnosis is mostly one of exclusion, and again, mostly clinical, but you're going to test for an abnormal vestibulo-ocular reflex, and I was going to look up exactly how that works, but I didn't. So that would probably be a good one to check another YouTube video on, the vestibulo-ocular reflex. That's something you can do in the office. Horizontal nystagmus, where it beats to the opposite side of the lesion. And we'll do an MRI again if we're worried about a stroke, if there's a lot of head and neck pain associated with this, inability to stand, same things we talked about before. This you can treat with corticosteroids to reduce the itis, the inflammation, and vestibular sedatives can be used like meclizine. This last one is kind of in a different class, and I don't know that it necessarily should have been included here, but in review books it'll be included with vertigo. So vasovagal syncope, like we talked about, is going to have some of that more vascular type presentation where it's not as much about spinning of the room or nausea and vomiting, but more just a lightheadedness with near syncope or syncope. And the history of this is going to have triggers like standing up, emotional triggers, happiness, worry are going to cause this. Pain, sleeplessness, urination, defecation, sex, and tickling can all trigger this, along with a lot of other things. And the main thing to treat it is just to avoid the triggers. People also use some beta blockers to treat this with some success, but the big thing is probably just to control the situations and not get triggered by this. So some of the patients that I've seen, for example, couldn't watch their favorite TV show, or if they did watch it, they had to just really be careful not to laugh too hard because they would get syncope. So there's one picture of nystagmus that I actually don't think it ended up here on the slides, so that one doesn't matter. But I did want to make a note that anybody who wanted to get involved and help out with this project, first of all, a comment is really valuable because it helps us to make these videos better. If you like or favorite or share the video, that helps out too. But really, we could use some volunteers to help with the project. The first phase of this project is to get a full-scale Step 1 and Step 2 USMLE review online, and Phase 2 of the project is to get a full medical school with all the curriculum in medical school online for free. So give me an email or leave a comment if